Welcome to part 3 of the patient experience. Here, we're going to cover output.
Good morning. Let's get started so that we can keep to our 30-minute allotted time. We'll start on 2 South and we'll move to 2 North. Ms. Cartwright is a new admission. Let's start with her.
Ms. Cartwright came in with chest pain, shortness of breath, and near syncope. She did not meet inpatient criteria at first, but we queried the doctor, and she does meet now. She's on telemetry with no rhythm changes since admission. She lives with her family in a mother-in-law suite. We don't anticipate any discharge barriers on her.
Business office. What are her benefits?
Business office. Interesting. Does your facility have a representative from the business office at every daily discharge meeting? You should.
Ms. Cartwright has Medicare with Blue Cross Blue Shield Secondary. Her benefits have been verified with both of the payers. She's not used any of her skill days this year. She still has all of her lifetime reserve days, and her Blue Cross Blue Shield policy will cover the deductibles and her co-pays. Her initial IM letter was issued on the date of admission.
Because she's been here over 3 days, we will need to issue another important message. Can you do that today? Because she'll possibly be going home tomorrow.
Yes, absolutely.
Coding. Do we have any outstanding queries or need any additional documentation to substantiate the accuracy of coding for the services we've provided?
No, we don't have any outstanding queries on this patient, and we have everything documented in the record that we need to accurately and appropriately code for billing purposes.
Nursing, have there been any changes that we need to be aware of?
It's important that the nursing representative comes prepared to discuss the current condition of the patient and the applicable changes throughout the stay. Listen to a well-prepared report.
Well, we've help locked her IV fluids, and when she hadn't had any complaints of shortness of breath, she's ambulated up and down the hall without distress. Her oxygen sats have been 96% or above, so we have taken her oxygen off, but we've left it in the room.
Sharon, can respiratory check and see if we can get the oxygen out of the room since it's not in use?
Okay, I'll call and get that discontinued.
We say we anticipate her discharge tomorrow, but it sounds like she could possibly leave today. Will you call Dr. Brown and see if this can happen?
I'll call him, and if he decides to keep her, I'll make sure that he adds documentation for that. I'll also ask for her telemetry to be discontinued because she's been running a sinus rhythm, and I hear that we need the telemetry beds.
Sounds like a good plan. Does anyone else have anything else to add? Okay, let's move on to Mr. Alvarez.
Mr. Alvarez is an immigrant. He does not speak much English, and he is a polysubstance abuser. He's homeless. He moves from shelter to shelter, and he's agreed to go to outpatient rehab. And I have asked Martha to take a look into this. That's the only thing that I can think of he's going to need.
Well, from a social worker point of view, this is going to be a difficult case because he has no payer source. I've already made referrals to several of our local outpatient psychiatric facilities, and Reds has agreed to accept him pending he can find a shelter that he will stay at for the entire duration of his treatment. His treatment is looking to be about 6 weeks, so I'm going to get with our local Jackson shelter to see if they'll agree to take this patient for those 6 weeks, because that's the only way Reds is going to take him for outpatient treatment. I'll follow up.
Kim, do we have any alternatives, any other alternatives for reimbursement?
There is a possibility that we can obtain reimbursement through the Medicaid program for Mr. Alvarez. We've already had our financial counselor pulling the required application for Medicaid. We will be getting with the nursing and the language line to make sure that we have a complete application prior to his discharge. The process for the application to the payment is about 4 to 6 months, so we'll have to follow up after the discharge.
Will you check with Cardin to see if they can help you with that Medicaid application process and possibly expedite it, because there is a program that will expedite it. Nursing.
He is currently on our detox protocol that includes D5LR at 100 milliliters an hour. He is a little groggy from the medications included in the protocol, so we have him on fall precautions. His Morse scale is 46, so if you go into the room, please make sure the fall precautions are being followed.
Does anyone else have anything else to add?
Yeah, when I completed his nutritional assessment, I noticed his albumin was real low and his BMI is 18. So I talked with the physician and we ordered a nutritional supplement 3 times a day with him.
Is the BMI documented in your notes or the physician notes? Because a BMI of 18 will affect the coding and reimbursement.
Yeah, it's there.
So with that BMI, we could possibly get a CC documented
There is
to increase that severity. Thank you for bringing that up. Let's move on to Ms. Mars in 243.
Ms. Morris is 72 and she came in with GI symptoms as an inpatient. She lives with her husband. The documentation does not support inpatient, and I referred the case to our physician advisor.
When the documentation does not support the current level of care, we must take the process one step further. This requires the case manager to refer the case to the physician advisor for review and intervention.
I wanted to talk to you about Ms. Morris. She's a Medicare beneficiary that was admitted yesterday, and we just can't seem to justify the inpatient level of care. It looks like she really meets observation, and by her being Medicare, I needed to know if you could help us out with this.
Yeah, I was looking over her case, and it looked like to me, you know, when she was admitted, they were concerned that she might require inpatient care. However, when she came in over the night, it looks like the labs are normal. They stopped the IV fluids at about 8 hours. It really doesn't look like that patient meets inpatient criteria. I think she was appropriate for observation, though.
Okay.
It seems obvious, but let's state the rule just for the record. The physician advisor must have a conversation with the attending physician to determine the appropriate documentation needs for level of care assignment.
Dr. Jones, this is Greg Oden. How are you doing today?
Great.
Good. I'm calling you in the role of physician advisor at this point. It looks like last night or yesterday we admitted Miss Morris. Is that correct?
Yeah, Ms. Morris.
That's what we thought. And I was looking through the record. Were you thinking when you admitted her that she was going to require an inpatient status?
Well, I saw Ms. Morris this morning and reviewed the record, and it did look like it'd be appropriate to have her in observation.
Yeah, when we were looking at the case, I agree with you at this point. It looks like the labs have all corrected. She's off IV fluids now. It looks like she's doing very well. Would you have any problem with us getting her changed to an observation status from inpatient?
No, that'd probably be fine.
Okay.
Probably a great recommendation.
Well, good. What we do here is there's a form that I will fill out, and I'll record my conversation with the utilization resource team that I agree with that decision. If you could, come back this evening and reflect those feelings in the chart and actually document that you'll be changing that patient to observation status. Can you do that for me?
Yeah, I'll take care of that. Thank you, Dr. Oden.
Thank you so much, Dr. Jones. We'll talk again.
Simple solution. The physician advisor must speak to the attending physician about decisions regarding the level of care. In this case, the attending agrees with the physician advisor. The physician advisor notes their conversation in the medical record. When the attending physician comes in later in the evening, he will write the status change order, changing the patient's status to observation.
Dr. Oden, here's the condition code 44 utilization form. If you'd complete that progress note for us and sign that you're in agreement.
Absolutely. All right.
Okay.
There we
I'll
go.
put it on the chart and I'll make sure the nurse is aware that Ms. Morris is now in observation through the condition code 44.
Right, and Dr. Jones will be by this evening to confirm that.
Thank you so much.
All right.
It's the rule. A condition code 44 form is required for all changes in status from inpatient to observation for Medicare patients. You probably knew that already, but a reminder never hurts.
Dr. Jones agreed that the documentation did not support inpatient status, and the attending agreed. We've got an order to change the observation, and we've notified the business office of a code 44. The form has been completed, and it's on the chart.
Kim, has the financial counselor informed the patient of what the actual financial responsibilities are and had her sign a financial responsibility letter?
And here's another rule. The hospital must notify a Medicare patient about a change in financial responsibility. Not a guideline, but a rule.
I'm not sure, but I will make sure that gets taken care of ASAP. I do know that she has both Medicare A and B, and the benefits are current. She has skilled days available and has not used any of her lifetime reserve days.
Coding. Are there any coding issues that need to be addressed?
No, there are no coding issues from our perspective.
Are there any other issues we need to address? If not, let's move on to North and we'll discuss Mr. Jackson.
Okay, Mr. Jackson is on day 9 of an ICU stay. They were unable to wean him, so he is possibly scheduled for a possible trach tomorrow. The doctor has agreed with our discharge plan, and we've consulted an LTAC. Mr. Jackson lives alone. He has 2 children, one in California. She would like for him to be closer to her. We did talk about the cost of transporting him out to California, and also the 50-mile radius provision that Medicare has. So she has agreed to go with the local LTAC. We've given them a patient choice list. They've made their top 3 choices. We've contacted them, and we should hear back from them by 3 o'clock.
Great work. How are we from the business office perspective?
The patient has Medicare Part A and B. He has used 34 lifetime reserve days, and since the patient is unresponsive, the son has signed the initial IM notice and will sign the subsequent form. The son does not have any access to the patient's finances and will be responsible for all the deductibles and copays.
From a coding standpoint, I know this is a complex case. Do you have any outstanding queries you need help with?
We do have one outstanding query relating to respiratory failure at the time of admission, and we will also definitely need to know if a trach is put in place, because that will make for a transfer DRG and change the coding perspective on that.
Melanie, will you follow up with the attending and make sure the query get answered? And that way the coding can code correctly and get that account taken care of. Nursing, dietary, rehab, anything else?
Well, during your intensivist rounds this morning, he's still on the vent. We've made several attempts to try to wean him, and we've been unsuccessful. He is on the lowest ventilator settings that we can put him on, have not been able to move him to a TP, so the plan is tomorrow for him to be trached. He is off all of his pressors at present. We've been 2 days without any pressor support. His abnormal labs were addressed this morning during rounds. Additionally, his son, you'd spoke about him, Melanie, he comes every day after he gets off work, and he's usually here about 5:30 in the unit visiting him. If anybody needs to get in touch with him, that's the best way. He's trying to work while his dad's been in the hospital for so long. He has a high risk for skin breakdown, so we're turning him every 2 hours. On the Braden scale, he's high, so the skin care protocol's in place. His tube feedings have progressed. We were having problems initially with high residuals, and now he's tolerating the tube feedings.
From a therapy perspective, we've been just providing passive range of motion 2 times a day. So from that perspective, he is within functional limits.
Yeah, his tube feed's meeting his needs, and he's tolerating well, so he should be able to continue that after his transfer. So no issues here.
Our plan sounds very good. It's just solid. Be sure we all follow up to make sure we have a clean resolution. Ms. Evans, can we move on?
Miss Evans is post-stroke. Physical therapy and speech therapy are following. She lives at home with her elderly husband. He's not going to be able to take care of her, so we've talked to her about a SNF placement. She's agreed. She's been given her the top 3 choice list. She's picked her top choice, and we're waiting to hear from them.
Dr. Brown ordered some potassium and sodium, and we're checking levels, and hopefully she'll be able to go home in the morning, or go to the SNF unit in the morning.
Nursing, any changes during the evening or this morning?
There's been no changes in her assessment. She's up in the chair this morning with the assistance of therapy and tolerating that well.
Candace, where are we from a rehab standpoint?
She's requiring minimal assist times too for all of her transfers. So right now she wouldn't be able to tolerate a more aggressive therapy program like inpatient rehab. But this morning, just before I came up, she had a barium swallow study done, which showed she had no aspiration, but they do want to hold on thin liquids right now until she has further speech therapy.
Do we have everything covered from a payer perspective?
Yes, Ms. Evans, the patient has Medicare Part A and B, has not used any of her lifetime reserve days. The patient also has Medicaid that will help with the SNF copays.
Has the spouse been included in all of the discharge planning and understands how the process is going to work? We just don't want him to have any surprises.
Yes, he's been included with everything. We've discussed the entire process with him. He's in agreement.
Okay. Are there any other patients we need to discuss? If not, thank you all for your participation, and I'll see you in the morning.
All right.
Have you noticed the patients discussed at the daily discharge planning meeting? All categories of patients. New admissions, length of stay greater than 3 days, private pay or minimal coverage, and patients with barriers to discharge.
As you have seen, patient flow and resource utilization assessment can be an extremely useful and productive tool for health management in our quest to enhance the patient experience throughout the hospital continuum. The key to the success of this process is to be proactive and not reactive when assessing hospital capacity and throughput. This more structured process for hospital capacity assessment and throughput can be accomplished through enhanced patient assessment, timely interventions, execution of the patient's plan of care, and effective interdisciplinary communication.
This is key. Effective interdisciplinary communication will improve both patient and facility outcomes. Input, throughput, output. Now that you've seen the entire patient experience in action, you can put it into practice every day.